as audio connected and take over. So we're the co-chairs of the ClinGen Low Penetrance Risk Allele Working Group. And over the last couple years, we've been trying to work on behalf of the community to better standardize and harmonize how we deal with these variants that have lower penetrance that can be kind of thorny when you come across them, especially in the clinical diagnostic labs, because they're hard to classify in our current high penetrance system. So for example, they may be too common in the population to cause highly penetrant disease, but there is evidence, there is some genetic evidence, usually through case control studies, for example, that they are playing a role in disease. So when you look in ClinVar for these type of variants, the classifications are all over the place, and the terminology we use in different groups is somewhat all over the place. And our practice with regard to whether we include them in diagnostic reports or exclude them, again, is variable. So our group set out to understand how people are handling these variants, and then kind of agree upon terminology to use to talk about these variants. And as we'll show in the slides, last year we focused a lot on coming up with a classification system for what we call risk alleles. So these are variants with very low penetrance. So that's the introduction. And let's see if Matt is ready from his side. If not, I will start from my side.
Okay, it looks like he maybe logged off.
Okay. Let me just keep going with slides. I'll share and then we'll keep it moving.
Thanks so much.
No problem. Yeah, so I'm going to show some slides that we initially showed on the December ClinGen call. So I want to recognize the contribution to everyone in our working group and Matt and Marcy Steves. So just kind of getting into this issue, you guys have probably seen this type of figure before, but it really is an important figure. So remember that a lot of the variants that we test for and think about for monogenic disorders, they are very severe variants in a single gene that have high penetrance, right? They're rare variants causing rare disease. So they're up here. That's that one single cause of disease that you can point to for a person. It's generally coming from that. If you have that variant, there's a high penetrance. There's not a lot of contribution from other genetic factors or environmental factors. As you move kind of across down to the lower right of this figure, you start to get into variants with intermediate penetrance, and then things that are involved in complex genetic traits where there's only one variant is having a very small contribution to the probability of you getting the disorder, but it still may be clinically significant in some manner. So in the introduction, before we start the slides, I introduced some of these challenges. So there's no universally agreed upon terminology. The variants are frequently too common, so thus they can get a benign classification. And you know, the criteria that we use for classification in our high penetrance system oftentimes fail. So here are some examples of risk alleles. So these are things with, again, very low penetrance. You really generally see these in case control studies rather than clear inheritance in families. But here's a common variant in the APC gene that has a odds ratio of around 2 for developing colon cancer. This variant in the MIT-F gene that's associated with melanoma risk, and then factor 2. So that's associated with thrombophilia. And this is a variant that had been tested for clinically for a while.
Right, I'm here now.
Oh, good. Yay. So did you want to add anything to what I've said thus far and maybe talk about this slide then?
No, we're going to get into a couple of these ones later on in sort of like a more hands-on type approach, so we can keep going, I think, for now.
Okay. Yeah, and let me know when it works to switch over to your side or what the plan is, but I'll just keep
Yeah,
going.
keep going, and then I'll when it's time, I'll switch over. It's going to be, yeah, I'll let you know.
And to the group, we certainly will have time to have an interactive discussion. I think that's what we want. But if there are any pressing clarification questions as we go, I think it's okay to interrupt. So, so this figure is kind of meant, and we've updated this over time, but it's meant to show what the world might look like if there are multiple classification frameworks existing in parallel. So kind of in our current universe, most of us are testing for these monogenic disorders. We're using this Mendelian framework where things are pathogenic, likely pathogenic, or uncertain significance. And you kind of get that classification as the output at the bottom right. We're imagining some type of future where there would be a different classification system that would work for risk alleles that would kind of operate in parallel to this Mendelian framework. But the goal is to come up with confidence measures that give us kind of that equivalent confidence. So a lot of people think of pathogenic as greater than 99% certainty of disease. So there's something we're calling established evidence. Likely pathogenic greater than 90%. So we're saying likely risk allele, and then uncertain. And then kind of based on the evidence involved and the penetrance, you would come out to this type of output, the top line classification at the bottom here. So here's established risk allele, likely risk allele, uncertain risk allele. And through discussions in our group and with the community, we've kind of carved the world, and by the world, I mean this spectrum of penetrance into things we call risk alleles. So these are very low penetrance, things that we call low penetrant variants. So you may be able to observe a pattern of inheritance in a family, but the penetrance is, not considered high. And then the high penetrance variants over here. Now the boundaries between these domains have been very difficult to pin down. So it depends on the disease area, and we haven't been able to come up with some quantitative separation that works for everyone in the community, but we have some qualitative definitions. So just to give a quick recap of our work with the risk alleles. So that was a lot of our focus of last year, and then this year is focused on what we call the low penetrance variant. So that class of variants that lies between the risk alleles and the high penetrance variants with regard to its penetrance. So we had three main activities in the working group. So we tried to come up with some guidance for evidence curation. So things that folks like yourself or other people that are looking at these variants, it's things they should consider when curating the literature to kind of bring everyone up to some baseline level of knowledge there. We developed a classification framework. I'll show you that proposed framework in some subsequent slides. So it's kind of like the high penetrance system in that there's criteria and there's classification tiers, but it's much simpler. And then considerations that laboratories and others might have in reporting these variants. We're not being prescriptive or telling anyone what to do, but we're just sharing some of the discussions we had in our group about the considerations that one might have when presented with this type of variant. So here's just an example of things you would consider when evaluating case control studies. So those association studies are going to be the primary type of genetic evidence for risk alleles. So it's important that we, be able to kind of curate the evidence from them in a standardized manner. And there are some key considerations. So a lot of those have to do with the study design. So properly phenotyping the individuals in the cases and the controls, matching them to try to get rid of the influence of other characteristics that might confound the analysis and give you a false association. There are different genetic models that people use with regard to these case control studies. Frequently you'll see allelic model or dominant model or recessive model, and then evaluating statistical significance, which is usually in the form of the p-value, and obviously that needs to be corrected for multiple hypothesis testing, and then the strength of effect, which is usually in the form of the odds ratio, and those are kind of two separate things, but both important to evaluate, and just recognizing potential sources of error such that we can evaluate the strength of the studies. One really key thing in this area, as you might be aware, is replication of the results. So that's a critical pillar to be able to have an association that is reproducible and clinically significant. So here's a bunch of painful words on the slide here, but just to kind of get the broad areas of this classification framework. Really, there aren't that many criteria that are relevant anymore. When we kind of looked at the high penetrance criteria, most of them kind of go away. They become not relevant for these very low penetrance variants. So what you're left with are the criteria supporting disease association in the form of primarily association studies. This is the big driver. This is the major factor that's telling you whether or not the risk allele is an established risk allele, likely risk allele, or uncertain risk allele. I will get into our guidance for the different levels of evidence here. We do see that functional studies can play a role, but it's a supporting role rather than a strong role that you see in the high penetrance variant classification system. And the reason for that is that with risk alleles, that variant that you're detecting, it's not necessarily true that variant itself is the causative variant that's conveying the risk. It may be genetically linked to another variant on the same allele, so essentially just a marker, and it may not function in the same manner as the high penetrance variant. So if there is a functional effect and we understand the mechanism of risk, then that becomes supporting evidence. But if that's not there, that does not suggest essentially benign evidence. It doesn't refute disease association. So what does refute disease association? Well, overwhelming association study evidence that refutes a prior finding. And this gets really tricky because with these association studies, frequently they don't always reproduce. They don't always replicate the result. And that can be because of chance. It can be because of different study designs and different populations studied. So just because a result isn't replicated once or twice, that doesn't give you evidence refuting a disease association. However, if a study is done that's larger, that's looking at a similar population and is better designed, and that shows no effect, that can refute an initial assertion that suggested that there was an association. Okay, so getting into the genetic evidence, you can see these bullet points at the levels of very strong, and limited evidence. And there's kind of three factors at each of those. And you want to have all three present to be able to declare that it's very strong. So you want to have a significant cohort size. Sorry, let me make sure my clicking is working here. You want to have replication of the result with little between study inconsistency. And you don't want to have the door open for bias to affect the association that's being reported. So you need all three of those things to be true to get you to very strong. Here's that figure blown up. So now let's go to keep this conversation a little bit more straightforward. I told you what very strong was. Let's talk about what limited is, and that essentially puts you into an uncertain significance category. So that just means there's an assertion that's been made, but you don't have the level of evidence to get to strong or very strong. And because there aren't population frequency constraints on risk alleles, every variant in theory could be a risk allele, right? It's not like we could just look through most of the variants we detect and immediately exclude them. It's based on whether or not there's this assertion. But if the assertion has not been made, we do not call it an uncertain risk allele. So it's not like you walk across the genome and you say every variant that could possibly exist is an uncertain risk allele. You would only give that label if an assertion has been made, but the evidence is limited. I hope that makes sense. And then the evidence strength of strong, which you'll see later is going to correlate to a likely risk allele, is somewhere in the middle. It's that you had these three things in place, but you didn't have enough for very strong. So there has been replication. There's no obvious bias, but it may be difficult to evaluate. And I know this seems like a very small number of individuals, but this is kind of a floor. It's not based on a extremely limited number of individuals. So you have more than one population studied. The result has been replicated, but it's not to this level of evidence. So just to kind of go into what I said about the functional studies again, this is supporting evidence. So it really, you'll see in a minute, it doesn't move the needle in terms of the classification, but it kind of gives you more confidence within that classification. So the key here is that the functional study is well established and there's a plausible disease mechanism. And that disease mechanism may or may not be the same mechanism as for high penetrance alleles in the same gene. That happens. I think one example we showed earlier was the MIT-F gene with the risk for melanoma. And sometimes you really need to think about whether or not these functional studies are better calibrated than we oftentimes see in the high penetrance variants, because it's reasonable that a risk allele effect could come from a small difference in function. So it's not like we're just looking at things that cause a total loss of function versus things that are totally benign. I mean, there might be a subtle difference here. So it's really important to have the right controls in place to detect subtle functional effects. So such as things as like benign variants, other things that are risk alleles. To really have that assay tuned to show an effect that's true and not give a false positive functional study result. And then this is just reiterating what I said earlier. The key takeaway is that if you have one study that doesn't show a significant effect, there are lots of reasons for that, and that alone does not refute the presence of a disease association. However, if you have studies with greater evidence in terms of the size and the quality of the study design and looking at a similar population, you can refute a previously reported association. So coming out with the classifications, again, very simple. This is what came out of all the work listening to the community here, but it's really driven by for risk alleles, driven by the genetic evidence in the form of these association studies. And if it's very strong, we say it's established. If it's strong, based on what I said before, it's likely. And if it's limited or refuted, it would be uncertain risk allele. Now, you can think of this kind of like a three-tier system with the magnitude of effect going towards increasing disease risk. So there exists the concept of a protective allele too that can be clinically significant. And while there are less examples of those, some of them are being reported now and are clinically significant. So I don't have it on this slide, but we've added to this system based on feedback, uncertain protective allele, likely protective allele, and established protective allele. So it's kind of the same thing, but in the opposite direction in that the association study suggested a protective effect on disease.
So Ryan, I can take over, but if you want to go back real quick.
Okay.
One thing. So yeah, and just to that point, I think one thing that this is sort of meant to be that there's data associated with like a particular variant that is either protective or a risk allele, as opposed to sort of the more wild type variant, at the wild type allele deposition. And so the idea of say like factor V Leiden or something being a risk variant, the wild type allele deposition is not meant to be called a protective allele. So it really is supposed to be sort of the variants that are like variants or the data, the variant that have the information against them. So if that makes sense. So we're not expecting people to sort of at one position classify one thing as risk allele and then the wild type as protective or something like that. It's sort of meant to be the data against sort of what the control population has. If that makes sense.
Yep. No, thanks for adding that.
All right, I can start sharing my slides. Ryan. It's going to be, yeah. All right, let me just present. Sorry, I was starting to add that in the second, having this be the protective allele and sort of being the same thing as well. So I'm going to talk a little bit about the reporting of these variants, just because that is part of our working group that we're talking about, although from the Biocurator aspect, maybe isn't as critical. But then I do want to get into some examples and sort of like go over some of these things on the call, and again, sort of hopefully have it be a little bit more interactive. So again, feel free to interrupt us as we're going through. For the reporting aspects of risk alleles, in general, ClinGen doesn't sort of talk about how or what you should report or put on your report or how to do that. And so we didn't want to make anything sort of prescriptive here or strict guidelines around the reporting, but we wanted to sort of give people some idea of how this is being used in practice. And so our approach for this was to sort of think about within our working group, sort of could we identify consensus on what people are or clinical labs and clinicians that are handling this data would do or would want with this information. So that's sort of our approach was more on like a consensus type thing, as opposed to being much more prescriptive on what you should or shouldn't do. So, I mean, some of it is pretty clear, like obviously information regarding penetrance should be included if available. It's oftentimes absolute risk information isn't going to be available, especially for risk alleles. You may have instances for low penetrant alleles where you have a little bit more concrete data on this. But ideally you could do some absolute risk, but oftentimes it's really not quite available. So that is sort of like what our goal is in the future. What we all want to be able to do is present more absolute risk, but I don't think we're quite there on having the exact numbers yet. For even when you should report a risk allele or not, there are many variants that potentially could be considered risk alleles, right? That are identified from GWAS data that have really low odds ratios of disease in the manner of like 1.5 or less fold increase. And we didn't want the consensus of the group was that those shouldn't be necessarily considered risk alleles. Oftentimes those are now getting included in polygenic risk scores and other approaches, but they're not sort of on their own enough to really sort of move the needle. And so as a group, we felt like it was comfortable and sort of applicable across medicine to have a sort of 2 to 3-fold increased risk of disease sort of being the lower bound. And so that's sort of, again, not prescriptive, but just sort of something to keep in mind when we're thinking about whether or not variants that you could statistically call a risk allele should even be sort of looked at in that regard or include on a report in that regard. The other thing, oftentimes you may identify risk alleles in a diagnostic setting for a particular disease. Because they are sort of only an increased risk and not sort of may not be sort of the only cause of disease. We didn't want, the group felt that in that setting, in a diagnostic setting, it shouldn't necessarily lead to like a positive report. That even if you found a risk allele associated to the disease of interest that the person has, you may want to consider calling that like an inconclusive report as opposed to positive, just because it's probably not the only thing that's sort of affecting whether or not they got the disease. So we also went through and tried to evaluate different scenarios for when a lab might actually encounter risk alleles, and sort of try to think through in specific scenarios what people may or may not do. So we talked about this one a little bit already, but identifying a risk allele variant, in this case associated with colorectal cancer, in someone who has colorectal cancer. And obviously you should report this, but again, not necessarily making the overall result positive. In instances where the indication doesn't match, and we're actually going to talk about this variant a little bit more, where there's an increased risk of melanoma, but you might actually find this on a panel for hearing loss. We didn't really reach a consensus of what you should do, but I think the reason was it's probably dependent upon what is consented, what the patient is consented for, right? And whether or not the lab discloses that they're going to be returning this type of information. If they're only returning things associated with hearing loss, and that's clear in the consent, then obviously you wouldn't necessarily want to return this risk, you wouldn't be able to, but sort of this is going to be dependent on sort of what the lab's policies are and how they consented, how the patient was consented for it. When we're talking about sort of prenatal diagnostics, there are multiple CNVs that are going to be sort of in this range and detected. The question was sort of what you should do if you identify sort of something in prenatal diagnostics. This was, again, you'll see there's a lot of things we necessarily couldn't come to consensus on. Another one where we didn't really have consensus on what you should do. And again, it's sort of dependent upon the reason for someone being tested, I think. And so if there is a specific reason, for instance, this one is associated with a VSD. If the person did have some sort of congenital heart defect, we may want to consider it in sort of the diagnostic setting. But if it's more of like a general prenatal test, and it's not necessarily associated with the findings, that there may not be warranted. And so again, it's more of a lab policy type question probably. And so that's why it was unclear from a group of sort of what should be happening here. For secondary findings, this is interesting because the guidelines, so this is the instance where you're the same APC variant that we talked about before, someone just coming in for exome sequencing has opted into secondary findings, and you identify sort of a risk allele, and what you should do with it. And the guidelines are mostly focused on highly penetrant conditions. I think the new ACMG V3 guidelines with the HFP homozygotes obviously is approaching sort of risk allele range. But I think it's, again, maybe sort of how these patients are consented for, whether or not this information should be returned, and sort of, again, more focused on the lab's policy for this. And it's a little unclear, I think, if this is warranted. I think most groups are not necessarily returning these risk alleles as secondary findings, but there was no clear guideline, I don't think, from the group of one way or the other. For a genomic screen, obviously, especially if the patient's consented for it, it was, yes, you should return these. That's sort of what they're being tested for. So that made sense. In the preconception carrier screening, we had an example, which honestly could also be sort of considered in this diagnostic setting, where the risk phenotype is actually associated with a different disease than sort of the carrier status testing. And in this setting, the consensus was sort of not to actually return the risk, but obviously to return the pathogenic variant. So this is an instance for GBA where the variant's pathogenic for Gaucher, but a risk variant for Parkinson's disease. And typically these types of risk variants are not sort of in the consent or not being looked at. So that's sort of why it felt like it was in that situation. Most often the lab would not end up wanting to return it. Yeah, so I guess that's quick. Again, I'm going to get a little bit into the more nitty gritty of actually going through some of these variants in a second, but we are sort of putting this together as a manuscript. We're pretty close to having it finalized. Hopefully we can get it out to the ClinGen community more broadly. What we're actually doing now, is some of you may see, is starting on the low penetrance stuff. So you'll notice this is all focused on how do we interpret the more risk alleles, things with case control type study data, and not necessarily things in the low penetrance side of things. We have solicited feedback from the ClinGen community, and a lot of people, especially people on this call, have replied with situations where it's challenging to interpret the low penetrant variants. It's actually showing that it's a really important thing for us to get this going too, because there's quite a bit of few groups have reached out to actually let us know that they're struggling with things in this realm. And so we are going to focus on the low penetrant alleles next and really talk to the ClinGen community a little bit more. So if you guys actually have specific examples, we're still accepting feedback and trying to listen to people about what instances they may have where they're coming across things that are proving to be challenging for them to interpret. So this is just a rundown of some of the people on our group. It's actually, it may not be the full list, but just people that contributed to one of our recent abstract submissions. But we have quite an active community, and we're always welcome to have more people join if they're interested in some of these things. All right, so with that, I think we're going to talk a little bit about some examples and sort of like how you might think through them. Again, please stop us on the way as we're doing this. And I may at some point in time switch over to like a form that we have that sort of helps us collect this information, but we may not need to for some of these ones. All right, so this is the first one. We're going to start sort of easy and sort of get a little bit harder. So this is the factor 2 variant, also called the prothrombin variant. And so you can see that there is a little bit of discordancies in ClinVar. If you sort of look a little bit more detail, people call it a range of different things from benign to VUS to pathogenic to risk factor. Partly this is due to the diseases being available, and also the fact that risk factor is not necessarily widely used within ClinVar right now. So ClinVar, and actually might even be available now, I think it is available now, has actually updated their submission to be able to accept these established risk allele, likely risk allele and uncertain risk allele terms. And so we're hoping more and more people will submit variants with that in mind, and sort of some of these discrepancies that you see sort of will be able to be resolved. You can see sort of when you take a look, it's a little bit all over the place. And so you may be sort of uncertain what to do with this. You also will notice that it's really quite common. So over 1% frequency across multiple different populations, and overall like a pretty high frequency. And so this is the type of thing that it's starting to be common enough that people may sort of be willing to leaning towards benign. But then with the ClinVar data, obviously there's some information there that you may want to look into. And so when you do dive in, there's actually quite a few studies that look at this variant. This is a very well-established variant. And you'll see that there's quite a bit of, there's also quite a few meta-analyses that have been done as well. And so here we're looking at just two different meta-analyses that have been done recently. And so this one is from 2013. One of the first meta-analyses sort of combined multiple different studies, and it has pretty decent numbers in terms of the overall. You can see from all the different studies, they're able to get to an overall odds ratio of around 2.8. for VTE. I think it's for VTE. They also actually looked at homozygotes, and hopefully you can see down here that in the homozygote realm, there's an increased odds ratio for those ones, for individuals who are homozygous for the variant in terms of VTE. And so this shows that there is pretty good data. There's even larger studies more recently that have sort of replicated this information. This is the prothrombin variant that we're looking at. You can see it's pretty high, or pretty similar odds ratios overall with really large numbers of cases and controls. So yeah, so I mean, I think this sort of just shows, again, this is a pretty more clear one, really large study, really well replicated, multiple actually meta-analyses looking at this data that clearly show that this variant is associated with an increased risk of VTE. And so when we're sort of thinking through that and putting it together, this is an example of what the evidence summary might be. And so we do clearly state early on that it's associated with an increased risk of VTE. Talk a little bit about how common it is in the population, and also how common VTE is. Mostly the reason we want to put this prevalence information is, and just so people understand what a little bit more of what the risk factor actually means, in some estimate for maybe the absolute risk, although we're not necessarily calculating the absolute risk for a variety of reasons. One other thing that's pretty important is actually understanding what the disease is. And so sometimes, this one was pretty clear, all the studies were sort of looking at the same event, but sometimes the studies may be looking at different outcomes. And so trying to think through how to actually combine those different outcomes or talk about those different outcomes is pretty important as well. This one does have a little bit of functional data. There's probably actually more functional data associated with it, but because the case control studies are so well established, it's a little bit less relevant here. Although it is useful to know if it seems to actually truly be the cause of the variant or not. And then the other one that's useful here is that we do sort of see, again, calling out homozygotes in addition to heterozygotes, in terms of having a different odds ratio, or an increased odds ratio from sort of the heterozygous carriers. In instances where it's important to really, where we have data to show that, it's important to sort of call that out. And there's other examples like factor V and ApoE and things like that, where homozygotes have an increased risk versus heterozygotes, and it's both of them are well established. So that's one, pretty easy. Again, if you guys have sort of more questions as we go through, please don't hesitate to ask. And Ryan, you can let me know if anyone has a question or raises a hand or anything as we're going through this.
Why don't we go through one more and then pause for questions? But if there's specific questions, just jump in.
All right. So this is a MIDF. This is one that we talked about a little bit. So MIDF is a gene associated with hearing loss, but also in this instance has a variant that's associated with risk for melanoma. And so this is the what you would see when you go to ClinVar is actually no conflicts for this one, which is sort of interesting. But you see there is a spectrum of likely path to sort of risk allele associated with this variant. It is a little less common than the Prothrombin variant that we were looking at, but still pretty high frequency, higher frequency than you might sort of expect for a variant associated hearing loss. But then you go in, and for this one, there actually isn't, there's one sort of case control study, but there really isn't actually any, I mean, it's one sort of meta-analysis, but there really isn't a lot of meta-analyses. So looking at this data set, these data sets are going to be slightly different in where we are sort of basing it on lots of different studies that are showing similar results with respectable sizes, but maybe not the largest of sizes. And so these were the first two, and actually two of the larger studies that have looked at this variant. And part of the reason is it's just a more rare variant. And so you're not going to have sort of the case numbers in terms of the like something like prothrombin that we're looking at. But you can see that it still does show with pretty good replication across studies and similar odds ratios, although the ranges are a little different, that there is an association with this variant and an increased risk of melanoma. There's a lot more other smaller studies that have come out since those first two that have sort of replicated similar findings, where there is a little bit of, these are all very small in terms of the numbers, but they all do show sort of a similar pattern of the risk for melanoma. Some of them show risk for other cancers as well. And so this is where it's talking about being clear what the outcomes are. And so in this instance, we definitely feel like there's enough data to call this variant a risk factor for melanoma, but less so for things like pheochromocytomas and some other conditions for renal cell carcinoma, things like that, where there's just not as much replication data or not as much, really the studies aren't as large, not as much replication data. So again, when you're starting to review these things and things that can be potentially classified against a few different conditions, really honing in on what the outcomes are from the studies is pretty important. This one also has pretty good functional data, sort of showing increased activity in terms of its versus the wild type allele, some downstream increased expression of downstream genes versus the wild type and other things. It's not sort of like the biggest home run, but again, the functional data in terms of the risk allele classifications is really much more supporting as opposed to sort of being much more definitive as it would be in the more Mendelian world. So again, pretty good data. It does get us from our things actually to the very strong level of evidence, because it has enough case control studies, it has been replicated enough. And so we do have a little bit enough information to really get to this very strong level of evidence. As you see, we do talk a little bit about, is this the one? There are, you may want to list like sort of multiple, I don't think we actually do it here, but sometimes we'll do this when there's multiple studies that have slightly different odds ratios. You can list them, each of the studies that have different odds ratios, and sort of get to a more standard, or show the range of studies, because there really hasn't been this sort of more well-established meta-analysis that's been done yet for them. Again, there was one sort of meta-analysis that is smaller, but in general, this one is more based upon probably the replication of the individual studies as opposed to like a large meta-analysis. All right, yeah, why don't we stop there and take some questions so we have time, and then we can, if we have time, get into one more that's a little bit even more challenging.
Hi, this is Maithili. I'm part of this group, and I've been wondering whether we should consent for risk alleles separately than the ACMG secondary findings. What does this group think about this? So like a separate opt-in for more risk allele type stuff? Yeah.
Yeah, I mean, there's fortunately not a lot of examples of risk alleles in the current ACMG findings, right? I mean, there's the APC variant is pretty well established. There's some for BRCA that are a little bit less well established. And then, I mean, HFB is sort of borderline anyway. But yeah, I mean, I think it does make sense, especially as these lists might expand, and you might get into things that are sort of getting into the where individual variants are more risk than sort of the Mendelian condition. That it probably does make sense, but.
And there are a bunch of questions and comments in the chat. I think some of those were answered. Thanks so much. But one here is, are the defined risk alleles exclusive to low penetrance alleles?
So we,
Maybe put that slide with that penetrance spectrum back up there to try to.
yeah, all right. Maybe, sorry, speed through this. Yeah, so we are trying to base things off of level of evidence, like sort of how much confidence do we have that this thing has an effect. So sort of established risk allele has the same level of confidence as a pathogenic low penetrant and as pathogenic, but that there is a little bit in terms of what you might call those variants, it might depend sort of on the more absolute risk of those things. And so that's sort of where we are trying to get to. It's a little uncertain sort of where these thresholds actually lie. And that's one of the things we're trying to work out now with the low penetrance stuff, is sort of trying to help define the boundaries in some ways between risk and low penetrant and sort of more high penetrant. But that's sort of where we're at. So we consider things to sort of more be on a spectrum. And so, yeah, these risk alleles are typically going to be more low penetrant in terms of their absolute penetrance than sort of the what we might call a low penetrant variant. If that makes sense, if I said that right.
Great. Any other questions?
Well, I'm trying to answer one in the chat, but it's hard to type it out. But I guess the issue was low penetrance versus variable expressivity.
Mm-hmm.
And, you know, that gets really complicated. I think that it depends how studies are set up, because both of those factors could influence whether or not a phenotype is measured. And of course, I would imagine that a lot of individuals where we say they don't have a trait or a disease, if you really look hard, you know, subclinically, they may have something you can measure. So I think it all depends on how the phenotyping is done. But that seemed like a very interesting example with respect to VHL.
Yeah, we've started to talk about this a little bit in our working group in the low penetrance spectrum, or in the low penetrance discussions that we're having, because there are, if it really is variable expressivity, but everyone does sort of seem to have one of the subphenotypes, then sort of we would not necessarily want to call those low penetrant, but sort of more call them out on sort of the fact that there can be variable expressivity. But if it is just that there's like a one subphenotype that they might sometimes get but don't always get, that's sort of where we try to lean a little bit more into low penetrance area. I know things aren't always that clean. And so any examples that we can get, so yes, we want to send that one, the examples along for VHL, that'd be awesome. Because we are trying to sort of now tease through these like edge cases, I guess.
And I see another question here in the chat from Josh. Regarding cohort sizes, does it make sense to set different evidence levels based on the phenotype being observed? For example, cardiovascular studies can be quite large compared to some others.
Yeah, I think I'll say the general concept, the cleaner the study design with regard to the phenotyping and also the effect size due to the variant, the easier it is to see an effect. So it just, without getting into cardiovascular versus other things, but just some conditions, it's just going to be easier to see a significant association than others if there's more noise in the system, as you might imagine. For example, you know, incomplete phenotyping where the controls have some subclinical thing or something like that. So when you have more noise, then you may need a larger study size. But yeah, that is interesting that certain conditions, for one reason or the other, if it's funding or access to specimens, tend to have order of magnitude larger cohort sizes.
Yeah, and also sort of a lot of the risk alleles that we typically think of are associated with more common conditions, right? To get the numbers to actually be able to show the sort of small effect size. And so while you can sort of have a risk allele for a rare condition, it's just you need such higher numbers to get there anyway, to be able to show that you have something that I think it's been a little, or it's much harder to collect the number of cases, I guess, to be able to show that statistically, right? So just by default, a lot of the risk alleles tend to be things with more common, that are more common, that have sort of larger numbers.
And there are a couple more questions in the chat. This is obviously a topic that people are super excited about. So is there potential for using these conceptual guidelines when dealing with recurrent CNVs associated with a known phenotypic range, but also known to show reduced penetrance, combined with the ClinGen CNV guidelines in some way?
Yeah, so we're starting to work on the low penetrance, and what we decided to do, as you sort of can see here, in some ways, is that the risk framework was really is more even better to think about this as like what the type of evidence is. And so if you have case control studies, meta-analyses type stuff, we're going to sort of use this risk wheel framework that we presented. That's sort of the way we based the analysis on. For things that are more on the low penetrance side, where you have more genetic evidence type stuff, what we're starting to do is think about how to modify the current guidelines for more Mendelian type conditions, whether it's the small variants or the CNVs, and as opposed to trying to create a new framework for those. And so the goal is to use the current ones, but sort of modify them to account for things that would fall under the low penetrance spectrum that might be more common than you'd expect, that sort of thing. And that's what we're working on. So we want to do that for both the types of information you'll find in the small variant guidelines and the ones in the CNV guidelines. That helps.
And I actually have a question that's come up for a couple of expert panels that I work with on recessive disorders. And apologies if I missed this, or maybe this will be part of the low penetrance work. But when thinking about recessive disorders, of course, you have to have a variant on each copy of the gene. So thinking specifically about hypomorphic variants where on their own or in homozygotes might not cause any symptoms or any signs of disease, but when in trans with a known pathogenic variant, will cause disease. So is that something that you're going to be looking at in terms of how to classify those or flag those in some way so they're not missed?
Yeah, that's a great question, and one that was actually part of our last working group call, and one that's been part of our working group calls in general. I mean, and you had another similar question for variants that just sort of show an enzymatic functional activity, but don't maybe show actually any phenotypic activity. And so yeah, I think it does seem to probably fall under the realm of our working group to think about variants that are more common than you would expect from a Mendelian standpoint, and how to think about classifying them. And so hypomorphs are a clear example of that, where the one that we always talk about, that I always bring up in our working group calls, is the TAR syndrome, where, yeah, it's a very common allele. It's not pathogenic on its own, even homozygous state, but with another pathogenic variant does lead to disease. And so those are ones that we are very much aware of, and I think would like to tackle and have as part of the low penetrance framework, but obviously they're not low penetrant, and so we need to think of them differently, but they would sort of be under the skies of things that are more common than you would expect, and how to sort of think about interpreting them.
Great. Yeah, we definitely have some examples from IEM and also ocular disorders. So I would love to keep in touch about those.
Yeah, there's quite a few ocular ones that we're learning about that we're not necessarily aware of. But.
Yeah, but you were inundated with responses to your email.
Yeah, no, it was great though.
There is one last question. I realize we're at the top of the hour, but one last one while you're here. What should happen in case if a variant was initially classified as likely risk allele, but additional studies showed no evidence of the variant being a risk allele? Oh, I see you've answered that already, Ryan.
Yeah, and that is why we have this category of uncertain risk allele is really for things that where the evidence has been refuted or just isn't good enough. And the uncertain categories, Ryan was saying, isn't meant to capture like all unknown things more like a VUS might. It really is meant to capture things that have had some evidence, but we really don't think it's there. Whether or not we ever want to have like a refuted one, I think if it was clear, if it was going to be clearly refuted and it's like there's just no one ever is going to think that it's a risk allele, we probably end up calling it like benign or whatever it might be, right? Based on the Mendelian framework. And so that's sort of the idea is you can downgrade these things and you should, but maybe if the evidence gets so strong, you would go back into the Mendelian framework and go outside of the risk one.
Right. I was specifically concerned situation if something was classified as likely risk allele, and well, let's say you have multiple very well-defined studies, and all of the studies showed it's not risk allele whatsoever, then uncertain risk allele term, but seems to be a little bit misleading.
Mm-hmm. Yeah, and I think that in that sense, like our recommendation would probably be to call it like the benign or whatever the Mendelian, like whatever would fit to in the Mendelian framework of things, right? And not, yeah, and maybe mention in the evidence that it's refuted for a risk, but we have not defined a refuted risk allele category, I guess. And I'm not sure, we may want to in the future, but it's just not part of what we've done so far.
Great. Okay, well, thank you both so much. Obviously, this has been a topic of a lot of interest, and look forward to hearing how things move forward as well. Thank you both so much for your time and for answering all the questions. And yeah, we just really appreciate all the expertise and all the work your group has done.
Yeah, and if anyone has specific questions or examples, please don't hesitate to email us, and hopefully we can come back on this call and not too long to talk about the low penetrance stuff. So
yeah, that would be fantastic. Thanks so much.
Great.
All right, and we'll look forward to seeing folks again in a couple of weeks on May 12th, when we'll be talking about computational predictors with Dr. Harrison and VCAS as well from the SVI. So thank you so much, everybody, and have a wonderful day.
Bye.